Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to be with us today. And without further ado, because we have a loaded show, I'll turn it over to the founder, Dr. Randall Maxey.
Good afternoon, everyone. And Dr. Walks, I did go to church today. I sat on the second row.
Okay. I was in church today also, Dr. Maxon. Yes,
And
sir.
the theme was Isaiah 6, and we talked about holy, holy, holy.
Okay.
Simon, let's put up the slides. So we want to talk about things that are in our environment, things that we do, things that can hurt us. And they hurt us disproportionately. And this happens in both products as well as procedures that are medical and that we find. And it may be that we have more problems with some of these things than do other cohorts of people. So the references we've used today include Journal of the American Medical Association, New England Journal of Medicine, Journal of the National Medical Association, British Medical Journal, Circulation, the Journal of Dermatology, and others. Let's go to the next slide. So just to get started, there's some abbreviations we're going to use as we go forward. For example, HTN stands for hypertension. CKD stands for chronic kidney disease. CVD stands for cardiovascular disease. GDMT stands for guidelines directed medical therapy. I started to say something else by mistake, Dr. Walks.
Don't say it.
SGLT2 is sodium glucose co-transporter inhibitor. That's something we know as Farxiga. NSMRA is non-steroidal mineralocorticoid receptors, and only one right now, and that's one called Corindia. UPF is ultra-processed foods. I thought that was ultimate octagon fighting at first. HR stands for hazard ratio, and RR for relative risk. And PM 2.5 is a fine particulate matter that's in the air. It's less than 2.5 microns. Next slide. These will become clear as we go along. So the molecular abbreviations include TGF beta, which is transforming growth factor beta. We're going to medical school. IL-6 is interleukin 6. It's pro-inflammatory cytokines. We heard about cytokines a lot with the COVID when it was bothering people. TNF alpha is tumor necrosis factor alpha. HPA is on the axis hypothalamic pituitary adrenal axis. That's for the psychiatrists to talk about. And DNA methylation, this is how things affect us, our genes epigenetically, and certain things can affect our genes and change it for generation. And AGEs are advanced glycylation end products, and these are things that affect you if your blood sugar is high. Next slide. This is too small for me. Can you see this, Dr. Neighbor-Stevens?
Dr. Neighbor-Stevens is on mute.
Okay. Can you see it, Dr. Walks?
I'm sure I can. And Dr. Hines, do not laugh at me as I try to read these little tiny words. TNF alpha, tumor necrosis factor alpha, pro-inflammatory.
I think we did this one already. Let's go to the next.
Yeah, we went through these. We didn't. Okay, we went through most of them.
Okay, continue to walk through this one.
Okay, how to interpret the dose response curves. The x-axis is usually the exposure level, for example, drinks per day or percent UPF intake. And then the y-axis, the one that goes up and down, is relative risk or hazard ratio. So HR or RR greater than 1.0 means increased risk. Linear curve is a steady increase in risk. A non-linear curve can mean an accelerated risk at higher exposures. So I'm sure we're going to see those in the next slide.
Next slide.
Not yet. Not yet, Dr. Maxey. Okay. All right. Interpreting hazard ratio, the HR. HR of 1.0, no difference in risk. HR of 1.5 means a 50% higher risk, and an HR of 2.0 means 100% higher risk. So, Dr. Maxey, when we go to HR 2.0, that means it's twice as much, so it's 100% higher, correct?
That's correct. Let's go
Okay, I went to
next.
public school. I gotta, I make sure you let me keep up.
I'm
And
public
confidence
too.
intervals determine statistical certainty.
Okay. Next slide, Simon. So there's an integrated mortality convergence model that includes what's the danger of smoking, alcohol, ultra-processed foods, cosmetics and chemicals, air pollution, medication gaps, and wound procedural risks. How do all these things work together, not for what God wants, but for what makes our cohort bad, makes our population bad? And we know they converge when it's inflammatory and vascular pathways that they converge at. Next slide. Dr. Neighbor-Stevens, you back on? Dr. Heinzen?
I'm here. Just
Okay, go ahead, Dr. Neighbor-Stevens.
so what is the way ultra processed foods cause their trouble? Emulsifiers go to in the gut, increase the gut's permeability after, which means things can pass through the gut wall after you eat them. Phosphate additives lead to vascular calcification due to problems in creating problems in the vascular wall. Ages lead to problem as you get older, you have more dysfunction of the endothelial wall or that vessel wall. Increased interleukin 6 or TNF alpha leads to the creation of plaques, medically known as atherosclerosis.
And that's also hardening of the arteries, we used to call it, right?
Before my time.
Before your time. Okay. Next
love
slide.
it.
UPF dose response relationship. Mortality risk increases proportionally with the intake percentage or how much of the bad stuff you take in. Meta-analysis show consistent dose gradient. In other words, it's showing how the more you take in, the more consistent the bad effects are, or the results of the bad effects.
Next slide.
Ultra,
Good.
did you want me to do it?
Yes.
Ultra processed food and dietary strategy. Well, that's simple. Don't eat it. Avoid processed meats, dark sodas, foods that have PHOS on it. Therapies. Replace UPF calories with whole, by which I think you're trying to convey nutritional foods. Sodium consumption needs to be less than 1,500 to 2,000 milligrams per day in high risk individuals. Actually, none of us need that much.
Right.
20 to 30 grams protein per meal. That is age dependent. Us old folks need more. Fiber is equal to or greater than 25 to 35 grams per day. Dr. Hines, I don't want to put you on the spot, but I think I read somewhere that 1,500 to 2,000 milligrams of sodium was about equal to a teaspoon a day. Is that what it equates to?
I know it's equal to a Big Mac.
I will look that up while you keep going.
Because I think it's important to give, I mean,
Yep.
I don't cook by milligram.
Right.
This was the next slide while she looks that up. All right, Dr. Hines, you want to take this one?
Sure, and then I can answer that it's not even 2,000 milligrams of sodium is a little less than half a teaspoon of table salt.
And then you put more salt on the French fries and more salt on the hamburger too, right?
Yeah, so
Total daily consumption, period.
yeah, so
Full stop.
yeah, that is a really good point. So 2,300 milligrams is roughly 1 teaspoon. So that's a really good point of reference. Thanks for pointing
Good
that
point.
out.
That's a good, excellent point.
So hair relaxers and the endocrine and epigenetic mechanisms. So phthalates and formaldehyde donors, as well, and estrogen receptor modulation and DNA methylation changes, weathering amplification, and frequency dependent hazard increase. So there's been a lot of discussion in the past about hair relaxers and what potential harms and increased cancer risks and those types of things. So when you're talking about DNA methylation changes, that's where you're looking at things that can impact, whether or not those cells come out normally in the long run. Similarly with estrogen receptor modulation, you're thinking about your breast cancers and those types of things.
So let me comment a minute on this one. I like this slide because it talks about formaldehyde donors. And one of my trainings right before medical school, I used to be an embalmer, and we use formaldehyde. And many of these products have formaldehyde as a preservative. And as a formaldehyde donor makes formaldehyde, and that can affect you epigenetically, and that can also affect your immune system and the methylation. And that weathering definitely means it ages you in addition. Go ahead, Dr. Hines.
And we're going to, while we're talking about relaxers, one of the other places where that's coming up recently is also you're seeing a lot of people talk about this with regard to synthetic braiding hair, and the chemicals that are in synthetic braiding hair have some of the same types of potential risks associated because of those chemical mixtures, and to your point, the preservatives and things that are there.
Next slide.
Before we go on, Dr. Maxey, I think that this is absolutely an area where folks need to talk with their local practitioner, their primary care person, because so many things are bad for you. And if hair relaxers are an important part of how you prepare yourself and you go about your day, it's just important not to say we can't do anything. And I don't know for a particular person whether, no, you can't get your hair braided anymore. You need to stop. So that's not what we're saying. I think we're saying that be aware of the risk and talk to folks. Is that fair, Dr. Hines? You're the family practice person.
Well, 100%, right? So for example, with regard to the hair braiding, there are growing lines of products that are, for lack of a better word, not chemical free, but meant to be remove some of these, more toxic related chemicals. Some of them are Black-owned businesses as well. But there's a lot of discourse in this space. So there are alternatives that can be used, because to your point, hair braiding is part of our cultural tradition for too many reasons. No lie relaxers, which are pretty much kind of the standard now, tend to be more endocrine safe, right, than some of the alternatives. So because these things are, and I will say that, they're sensitive scalp formulations, they have mild relaxer formulations, there's absolutely an increase in the popularity of natural hair and natural hair styling tips and keratin formulate. There's a lot of different alternatives that people are looking to in response to the increased knowledge around some of the potential consequences of using hair relaxers, synthetic hair, especially when we're talking about some of the older formulations.
And that word weathering amplification, I think that means you start looking old sooner. Next slide.
So
Go ahead.
hair and skin product safety counseling. So avoid frequent chemical relaxers. And we also, another thing that comes up are unregulated skin lightening products. This has been a topic of discussion for a number of years. And as even from the cosmetic perspective too, just because sometimes you're doing permanent damage to the melanated areas of your skin, getting overcorrection, we'll say, because lots of people have dark spots, especially on their face, for a number of reasons: acne scars, the melasma that we get during pregnancy, during and after pregnancy, any other types of scars. There's a lot of reasons why people might want to lighten in dark spots outside of being having an aversion to the actual color of their skin. But being clear about, to your point, Dr. Walks, about the products that you use, sometimes your dermatologist might also be a good resource in that space as well. And then as far as therapy, safer hair alternatives, they are around. Unfortunately, at least in my area, I don't see them so much at my local at my local hair store. So you might have to put a little bit more forward thinking into what some of those strategies are going to be, so that then you can have delivery time and that type of thing. Patch testing is when you put the chemical on a small section of your hair or your scalp, because sensitivity, the itching that sometimes comes with some of these styles, the itching isn't just because your hair is too tight. Sometimes the itching is because the chemicals are there. One of the other things that you'll see is pre-washed hair. Pre-washed hair is, again, trying to get rid of some of those chemicals as well. And then, talking with your dermatologist if you are finding that you're having any chronic scalp irritation, unexplained hair loss. Not all hair loss. There is menopausal and perimenopausal hair loss, but it's not always just that.
So Dr. Walsh, maybe just briefly comment on why people want to lighten their skin and dark people want to get light, light people want to get dark. What's the psychiatry behind that?
Dr. Maxey, I'm trying to address that quickly is very, very hard. There are so many reasons. Most of it has to do with what is the cultural norm? What am I supposed to look like? We know that within African American culture, there's a history of the paper bag test. You got to be lighter than this paper bag to go here or marry this person. So it's always about what is pretty, what is nice, how am I supposed to look so I can be considered attractive, so I can consider myself attractive. And there are a lot of folks who are in a lot of therapy sessions about how they look and how they're supposed to look. So it's a real big deal, particularly in our culture, that a large part of that, how do I look and what's pretty, has to do with the tone of our skin. Though some of the most beautiful people are what we used to call blue-black. I love me some blue-black people. The darker the berry, never mind. Go ahead, Dr. Maxey.
Is Dr. Lawson on?
Dr. Lawson is on.
Is he muted?
He is muted. We might spend the whole day talking about why folks want to address their skin color.
Let's go to the next slide then.
You mentioned in the chat Dr. Welsing's concept of color.
That was her theory, the Kress theory of color confrontation.
Yeah, yeah, I'm unmuted now.
Okay.
Yeah, that idea that Walton has actually not the original, though she likes to present it as original. The idea that dark skin is supposed to be genetically more dominant and also associated with strength and so forth. And in some other countries, such as South Africa, the whole idea was that this dark-skinned person, if they mate with regular white folks, they'll take over the world. They'll replace white people. And so the whole idea was to suppress dark-skinned people because of their genetic superiority in terms of being able to transmit that characteristic. And the other part is if you see dark people as strong, then you want to get a suntan or however darken your skin to acquire their sexual prowess and strength.
Thank you very much. I'll take this slide. So we know that there's amplification with the use of alcohol. It affects the sympathetic nervous system, which raises blood pressure. It causes oxidative myocardial stress, which leads to cardiomyopathies and heart attacks, and the atrial fibrillation risk as well. Next slide. So for tobacco, we want to avoid menthol cigarettes. We know that they're marketed more to Black people, and there are also flavored cigars that happen. And the therapies that we use are to try to stop people from smoking in general, but especially stop from smoking methylated cigarettes. We need to have nicotine replacement programs, and it's because of they market these so heavily in communities of color. So the tobacco bothers you, and the menthol lets you think you're not being hurted. It's not more gentle. Next slide. Um, this air pollution is something that can affect your blood vessels as well. And we know that these little compounds, the PM 2.5, they're smaller than a hair, and they cause oxidative stress, which affects your endothelium, which is the inside lining of your blood vessels. That causes stiff blood vessels, high blood pressure, and plaque instability. And that, of course, can lead to embolism as well as stroke. Next slide.
Hold on, Dr. Maxey, before you go past this one. Those of us who grew up in Los Angeles know about air pollution and trying to go to outside practice in the afternoon when it used to be really bad and actually hurting when you breathe in because of the smog. A couple of days ago, the American president did roll back all of those environmental protections, and we should expect air quality to get much worse. So when we talk about this whole effect of bad air or air pollution, all the stuff that comes out of factories and car exhaust pipes and everything, it's about to get worse, and it's already bad for us. And we won't even talk about all of the asthma and everything else that is going to be worse in our community because of what's happening politically.
And who lives in the communities that have the worst air? Us.
Yeah.
And
Yeah.
this slide shows a dose response curve that's simply basically saying that the more you're exposed to, the worse it is. Let's go to more mortality, more cardiovascular risk, etc. Let's go to the next slide. So someone on this phone call, namely our technician, is an auto mechanic, and he's exposed to diesel, to solvents, to brake dust, and this can affect you. Smoking also can, marijuana can affect you. Combustion particulates are very bad. So I used to tell people it's better to smoke, to eat marijuana than to smoke it, but it's bad both ways, but especially smoking. And also, we know that people who work in restaurants, especially if it's a small kitchen, if they fry stuff, that's aerosolized, and they breathe it in. The wildfire smoke, we had big fires in California all the time, but especially in Palisades, and that wildfire smoke can be deadly. And we know that refined carb spikes, such as I had pancakes yesterday, So pancakes can lead to oxidative stress. My favorite meal. So we should understand that these things are bad. Next
I
slide.
gotta throw a flag, Dr. Maxey. You can't take away everything. Everything is bad for me. I can't go to Popeyes. Now I can't even have pancakes. Come on, man.
Not only that, there are ways that you can modify the bad components of pancakes. For example, using different kinds of flour bases, the nut bases in particular, um, and using um, a griddle or a skillet and not letting it smoke.
That's a really good point. Really good
Thank
point.
you.
I perceive it.
Does that help you, Dr. Walks?
Yes, ma'am. Thank you so much. I'll be
So
at your house next Saturday for breakfast.
Hey, Dr. Walks, I'm going with you. Dr. Neighbor Superman promised me some meatloaf for so long. Next slide. Dr. Neighbor Superman, take this one.
Okay. I'd love to. Environmental exposure reduction. We want to avoid high pollution zones when possible, and we want to avoid indoor smoke exposure. Therapies, HEPA filtration, whether you're talking about your air filter system or your vacuum cleaner system, those help. They're not the end all, but they help. You want to use a mask on those days when they put out the allergy alerts or the pollution alerts, which unfortunately happen more frequently than we would like. And I wanted to make the comment on the wildfires. You know, you were talking about the Palisades, but the Palisades and all of those West Coast and Canadian fires, their smoke
Mhm.
are reaching down all the way down to Tennessee. It's not like you can run away from this. This is enveloping the whole earth. Uh, we want to advocate for policy, which is a challenge, but it's what we have to do. Like it with everything else that needs to be fixed, it isn't going to happen unless we get to pushing on it. Blood lead screening in high risk populations. Well, yes, this is absolutely important. I think the reason I hesitate when saying that is who and where are the high risk populations? Therein lies the problem. Because
And that's why they're letting it go. That's why I like to go to Jamaica.
children are routinely screened up until about 3 years of age, no matter where they live, and longer if they live in a residence that has been identified as having a lead risk. But a lot of the lead poisoning happens because of environmental lead poisoning, i.e., there are old factory sites or battery burial places and all that kind of stuff, and you don't even know it's under there, and you are exposed. It leaks into water supply, all this kind of stuff. Not to mention the lead pipes that are still very prevalent in a lot of housing.
Yeah.
Mm. Next slide. Dr. Walks?
Integrated prevention model. One, remove high risk exposures to the extent you can. Aggressively treat cardiometabolic disease. Monitor early for albumin in your urine, blood pressure, A1C. Address stress and sleep. And then ensure multidisciplinary collaboration. So make sure your different practitioners and providers are talking to each other and all talking to you. Exposure reduction plus pharmacologic protection equals mortality reduction. Amen.
So what
Next
was
slide.
that last point you're making, Dr. Walks? Is a lot of people say, I don't want any drugs. I don't want, just want natural stuff. Nowadays, it's important to consider pharmacologic intervention when it's good, when it's necessary. And we'll talk more about that later. Dr. Hines, take the next slide if you would.
The air pollution dose response. So the higher the PM 2.5 correlates with a higher cardiovascular mortality.
Take the next slide if you would.
So the definition of the PM 2.5, particulate matter less than or equal to 2.5 micrometers. So those are small enough to be able to penetrate the alveoli and the bloodstream. So the alveoli are the tiny little sacs on the inside of your lungs where the actual air exchange occurs. Where that, switches between the oxygen and the carbon dioxide goes so that then the oxygen can get into the blood. And that is associated with increased risk of cardiovascular disease, renal disease, and neurological risk, according to an article in JAMA from 2002.
Dr. Lawson, take the next slide if you would.
Oxidative stress, simple explanation. Excessive reactive oxygen species, damage to lipids, proteins, DNA, triggers inflammation, central driver of pollution-related vascular disease.
So this pollution is something. That's why I like the Caribbean. If Dr. Dawes on, Dr. Walsh, we got to go visit her in Jamaica so we can breathe free for a little bit.
Don't
Dr.
threaten me with a
Maxey?
good time. I'm ready to go.
Yeah. Dr. Max, I just want to make one other point that we hadn't made earlier. That is that not only our colleague Carl Bell made strong point in multiple studies that he's referenced, showing that a lot of some of the so-called inner city behavioral issues, drug abuse, homicide, suicide, is directly related to the degree to which folks are exposed to such, especially heavy metal pollution, but other kinds of pollution as well.
Mm.
Yeah, that's good. Next slide. You want to talk about this, Dr. Barbara Neighbor-Stevens?
Thank you. This is a common exposure comparison, looking at the relationship of or the amount of exposure based on the site of the exposure. So outdoor urban, to my surprise, honestly, I think this might be somewhat dependent to Dr. Walker's point as to where you are. But outdoor urban is at the lowest rate. Not surprisingly, wildfires are going to be high. We talked about what happens to the cooks in small kitchens with restaurant frying, but the maximum exposure rate is with smoking.
So smoking has a lot of psychiatric reasons, right? It's oral gratification and all the other things. We'll deal with that another time. Next slide. Is that part of the Oedipus complex? Dr. Walks?
I'm gonna leave you alone, Dr. Maxey. I think they do have an evening service though. You can get back on the second row this evening. Epigenetic weathering mechanism, chronic psychological stress, DNA methylation alterations, telomere shortening, and accelerated biological aging. So all this stuff is bad, and all of it can have absolute long-term, and it can kill you. It can make your life bad.
So on that first point you made there, I understand that one of the strongest psychological stresses is financial distress. That can be more effective in creating this level. Is that what you've seen, Dr. Walsh or Lawson?
Well, the short answer is yes. I think that also, since we're talking about overall health, when we talk about financial stress may be the number one reason that folks break up. Messing up marriages and breaking up families. This is not a minor thing. So
I just saw a note in someone saying about the asked about telomere, and things related to the talk that I gave last week. Again, the telomeres are a predictor about life expectancy. It is the shortening of that mechanism determines how long you live. So if your telomeres are shortening, it means that you're giving up years of life.
And the telomere is the little end of the chromosome.
Right.
Yeah.
Is there anything to make them longer? Does turmeric affect that?
Indirectly, there is some evidence that you can. No one has done a prospective study, as far as I know, has shown whether or not lengthening telomeres will make you live longer. There's some people trying to do it, but as far as I know, no one's succeeded successfully yet.
Okay. Let's go to the next slide. Dr. Hines?
Medication and procedural disparities. So there are delayed starts for SGLT2 inhibitors. There is an underprescription of NSMRAs. There's therapeutic inertia when it comes to resistant hypertension, and delayed specialty referrals. So what some of those things look like, and I see this a lot, is especially the resistant hypertension, your blood pressure is 100 over 180 over 100, and then you get one blood pressure medicine. The likelihood that one blood pressure medicine is going to get you to goal is really, really, really slim, right? And then the other place you see that some of these things come up is, oh yeah, let's start this, and then we'll see you back in 3 months. And then it takes us 2 and 3 years to finally get your blood pressure to goal, or any of these things, right? Get your diabetes, get any of these things under control, because you're only coming in quarterly for things that could be moved along a little bit quicker. And similar, it's a similar kind of thing with some of the slow to starts, reminding people that this is an option, especially, we sometimes as primary docs, there's a lot of things. You have your habits, so changing people's habits, right? To incorporate newer medications, sometimes we need a little nudge.
You brought up a very important point in one of the articles that I read, that we used to say start one drug for high blood pressure, then add another and another and another. But now the FDA has recently approved in the past few months, drugs that have 4 medications in one. Treat them all at once: a beta blocker, an ACE inhibitor, or an angiotensin receptor blocking agent, a calcium channel blocker, and a thiazide or chlorthalidone, all at one time in one pill. And they're thinking, don't just ramp up, but treat that high blood pressure, because there can be a lot of problems with it if you don't treat it. It causes soft damage very slowly, but it's not reversible. So it's important to treat that high blood pressure at once. And when I see people with high blood pressure, I have them come back in 1 or no more than 2 weeks to see if I'm getting control of what I'm doing. You have to monitor that very much. Next slide.
So keloids and wound care prevention. So to avoid, so we all get scars, we all get cuts, right? And some of us are getting, those things intentionally with our piercings, with our tattoos, those kinds of things. So how you can avoid the formation of keloids is avoid high tension closures when we're talking about if you get those stitches put in. And then avoid delayed scar management. So if you see that as this wound is healing, it's not looking like it's going to be flat, if it's heaped up, those kinds of things, if it's not looking quite right, if it broke open in certain areas before the stitches were able to come out, all of those things you want to act on sooner rather than later. Some of the therapies that are around and available to minimize scars are silicone gel sheeting, and you want to use that early in the wound healing process. Early means, once the skin is closed and it's not necessarily an open wound, that's early, right? Intralesional corticosteroids are good for reducing the size of keloids. pressure therapy. While you can do that formula, you can also do that on your own at home, and it is literally what it sounds like. You are using pressure to break up some of that scar tissue while early when your wound is healing, and then radiation can be used in more severe or refractory cases. And if you have keloids, if you know that runs in your family, you want to be especially diligent in taking proactive steps for wounds and scars.
Next slide, that's neighbor Stephen.
Cardiorenal protection therapies. You want to avoid therapeutic inertia, which means don't wait. Therapies. Early SGLT2 inhibitors in chronic kidney disease and diabetes. NSMRA for proteinuric chronic kidney disease. Blood pressure target individualized, but often less than 130/80. And routine albuminuria screening. I want to go back to NSMRA for proteinuric chronic kidney disease. Is there any chronic kidney disease where you don't see protein in the urine?
Yes.
What is it?
Stage 1, CKD, you don't necessarily see proteinuria.
Oh, okay. I misunderstood what you meant. I didn't understand you meant at the stages, because I thought protein was one of the main things. But I get you. You just mean in the early stage it might not be there.
Yeah, so one of the things you want to measure is something called ACR, albumin creatinine ratio. And if that amount of protein in the urine is above 30 milligrams, you want to then start the Farxiga and the Corindia, which is the NSMRA, because that proteinuria can be stopped a lot. And there's tubular damage that also happens, as well as glomerular damage that happens in there. Let's go to the next slide. Dr. Walks.
Clinical case 1, menthol and resistant hypertension. 52-year-old African-American male with hypertension, chronic kidney disease stage 3, who smokes menthol cigarettes daily. Bless his heart. Mechanism: the nicotine in the menthol lead to sympathetic activation, which increases the blood pressure and decreases the endothelial function. The intervention would be varenicline in combination NRT, tight blood pressure control, getting it less than 130/80, and SGLT2 inhibition initiation.
So again, people think everything can be natural, but it cannot be. You can't just stop smoking. And I won't tell you what we talked about in church today, but you need help on some of these things. And right now, some of these pharmaceuticals are the best things that we have. Next slide.
So Dr. Maxey, let me just add quickly on this. One of the other challenges we talked about, folks starting slow, and Dr. Hines was talking about how by the time they get you on some effective medicine, all this time has gone by. The other thing that goes by is your health. So many times the insurance won't approve the better medication or the one that will keep you healthy until you get sicker. And I think that is an advocacy issue for us. That is a place where we have to advocate with our primary care providers and others to say, wait a minute, why do I have to wait until I have this consequence of an illness before we can prevent the illness from getting worse or help us to get better?
Another thing you bring up, like the things that we want and things that we say we had to have our insurance pay for. If it's going to save your life or your loved one's life, you might have to pay out of pocket temporarily until they can get the insurance issue solved. But we take vacations, we fly first class here, we buy Johnny Walker Black. So we can spend some money. We can spend some money if needed.
No pancakes and no Johnny Walker Black? Come on, man.
Dr. Hines?
So clinical case number 2, involving hair relaxers and gynecological risk. So you've got a 48-year-old African-American woman who's a longtime chemical relaxer user who starts having abnormal uterine bleeding. So the mechanism of that could be phthalate exposures from the chronic relaxers, which leads to estrogen receptor signaling, which leads to epigenetic DNA methylation shifts, and potentially uterine cancers. So the intervention, so we're going to get a gynecological referral, discuss exposure reduction, and screen for metabolic risk.
Okay, let's go next slide. We got to go a little bit faster as we go forward.
So clinical case number 3, there's a chronic wound and a keloid risk. So we've got a diabetic patient with a foot ulcer and a history of hypertrophic scarring. So the mechanism there is chronic inflammation leads to TGF-beta activation and fibroblast overproliferation. The intervention there is going to minimize wound tension, early silicone therapy with regard to treating the ulcer, and consider intralesional steroid at closure.
Okay, let's go to the next slide, Dr. Lawson.
UPF and cardiorenal acceleration. 60-year-old with diabetes and hypertension, diet high in processed meats and sodas. Mechanism, phosphate additives and leading to vascular calcification. AGEs, leading to endothelial dysfunction. And the intervention, of course, is to reduce the UPF by 20%, reduce the sodium to 1,500, 2,000 milligrams a day, and to monitor the ACR and BP, blood pressure.
That ACR is the albumin creatinine ratio. You want to check it here. Next slide. So talk about this, Dr. Lawson.
APA axis activation, hypothalamic pituitary adrenal axis is an important chronic stress pathway. Pollution by itself can lead to cortical elevation as well as stress, and it promotes hypertension as well as insulin resistance.
Next slide. So we know that aggressive cardiometabolic risk must be handled as much as you can. When I target that blood pressure, I don't like 130 over 80, I like 120 over 80. But you have to individualize it. Some people need just a little bit more pressure to get blood through those small arteries. Want to keep the LDL, the low density lipoprotein, less than 70. But that's a high risk setting that gives you heart attacks. It's your bad cholesterol. We want to make sure you optimize the A1C as close to being under 5.7 as possible. And with the A1C, it measures your glucose level over a 3-month period. So it's a number that you want to keep as tightly down as possible. The other thing we want to measure, and nowadays, is your amount of insulin in your blood. There's some insulin concentration we want to measure. And we also know we want to decrease visceral fat. So fat around your abdomen means there's fat around your organs, around your heart, etc. And also want to make sure you have an anti-inflammatory diet and exercise as much as you can. Next slide. Dr. Neighbor-Stephens.
Ooh, this is another one of those seafood and sushi considerations. We have a serious problem with mercury pollution in all of our big waterways, and I don't mean our lakes, I mean our oceans. We also have major plastic pollution, both macro and micro, in our oceans and our waterways. So it's really a difficult decision. When you're at the grocery store and I look at and it says wild caught, and it tells me where it was caught, and it tells me if it was farm raised. It's a real hard decision trying to figure out what's the best of probably 2 bad choices. And not to leave out infection risk for those who are immunocompromised. And there are a number of individuals with a number of diseases who are on either the disease or they're on medications for the disease that leaves their bodies unable to resist infection as completely and effectively as they would have prior to being in the situation they were in.
Okay. Next slide, Dr. Walks.
Clinical takeaway for hospital staff. Air pollution is a modifiable cardiovascular risk factor. Screen vulnerable patients, integrate environmental history into the assessment, and educate on HEPA, AQI, and exposure reduction.
Dr. Hines, take the next slide.
Hidden dangers of illegally reprocessed snack foods. So,
Go to the next slide.
so the problem, there is food fraud in snack manufacturing. And so there is the reuse of expired snack products. So think about grinding mold contaminated foods into powder, relabeling with falsified expiration dates, distribution through informal or discount markets.
Take the next slide,
Big-
too.
That's a real big one.
So mold growth in expired snacks. So some common molds that can be found in expired snacks is going to be Aspergillus, Penicillium, Fusarium, and the production of heat-resistant mycotoxins. And grinding does not destroy toxins, and reprocessing only increases contamination spread.
Dr. Lawson, take the next slide. We're almost done.
Mycotoxins and health risks. Aflatoxins and liver carcinogens. Ochratoxin A, kidney toxicity, fumonisms, neuro and negative and hepatic effects, chronic exposure linked to cancer and immune suppression.
Next slide. Dr. Neighbor Stevens.
Rancid oils and oxidative damage. Oxidative lipids and aldehydes. They increase the oxidative stress, they increase endothelial dysfunction, and they contribute to diabetes and cardiovascular poor health and disease.
Okay, next slide, Dr. Walks. We're almost done.
Impact on chronic disease. Worsening chronic kidney disease progression, increased proteinuria risk, amplified inflammation, and higher risk in vulnerable populations.
Next slide, Dr. Hines.
Gastrointestinal and immune effects. So there is increased gut permeability when there is, and which causes microbiome disruption, chronic inflammatory responses, and possible endotoxin translocation.
Next slide, Dr. Lawson.
Vulnerable populations, children and elderly, immunocompromised individuals, low-income communities, patients with diabetes, hypertension, and chronic kidney disease.
Next slide. So we know that a lot of people violate the FDA Food and Safety Modernization Act. They do that on purpose. There's a lot of food adulteration and labeling is fraudulent sometimes. There's criminal liability and civil penalties, probably if you're Black. We know that this is a public health problem that we need to look at. Next slide. I'm going to take this down, neighbors, Ibbins.
Okay, clinical case consideration. An elderly diabetic chronic kidney disease patient who comes in with a chronic snack consumption from discount outlets, mild transaminitis, and which is an inflammation, increase in liver function test, and GI symptoms. Consider environmental toxin exposure.
Would they do that at the 99-cent store? Is some of that stuff fit this category, I wonder? I won't get in trouble. Next slide. We're almost done.
Me?
Dr. Fox.
On me? All
Yeah.
right, patient education recommendations. Avoid damaged or deeply discounted packaged snacks if you can't avoid them altogether. Check expiration dates carefully. Avoid bulk repackaged unbranded snacks. Report suspicious food products.
You know,
Next slide.
I check dates on everything. And yesterday when I was at the store, they had a particular brand of coffee, two for the price of one. And as high as coffee has been lately, it caught my eye, of course. And I tell you, it was almost impossible. I finally found the best by date, but it was very difficult to see. So don't get frustrated. Look for it.
Yep.
Good point. Good point. Next slide. Dr. Hines.
Counseling integration, chronic kidney disease counseling integration. So limit processed snack intake, avoid phosphorus additives, reduce your sodium load, and prioritize fresh whole foods. Can I make a request though on this particular topic? Because I have questions. I wasn't aware of the whole repackaging and reprocessing. And as things get more expensive and people are looking for deals, right? Because you can buy food anywhere, right? Target, Marshalls, Walmart, Ollie's, $5 store, all of that. So I would love to have another discussion on what are the clues that some of this stuff is repackaged and repurposed and that kind of thing.
So probably the best thing is don't eat too many snacks. Period.
I mean, that would be lovely.
I remember on airlines they used to serve peanuts. Now they serve these things you never heard of, and you eat them.
But
Right.
it's not just food, and some, there was a lot of litigation around the toothpaste that was being sold in some of the dollar stores
Oh,
that,
yeah.
you know, it's, yeah.
All the topical like the topical products. And again, I think it's a really good potential thing for us to discuss in greater detail, because how do you know? Like, what am I looking for? Because to your point, okay, an expiration date, great. But if it's been repurposed and reconstituted and whatever, it's likely going to have a new expiration date. So that didn't
Help you.
tell me.
No. Okay, next slide. I'm trying to get through this deck. Let's go to the next slide.
Grinding moldy food does not eliminate toxins. Heat does not neutralize most mycotoxins. Chronic low dose exposure is harmful, and clinical awareness improves prevention.
Next slide, Dr. Lawson. Let's hope we're almost at the end. Well, I guess we are at the end. So I think just as a summary, be careful what you put on or in your body. There are things out there that can hurt you, both temporarily and also fatally. And I saw one question come up from one of our viewers, asked about hair coloring. What about hair coloring? I asked you, Dr. Hines and Dr. Nabor-Stevens, how does that affect the body?
Well, there has been in this whole conversation before the relaxer conversation started was the coloring conversation. So all of this has been up in the air for years. And how does it hurt you? There are toxic chemicals in the coloring agents, and they are absorbed into the skin.
I will also add, similar to the ways that relaxers have evolved, modern hair dyes have they've been studied, right, and have lower overall risks of some of those carcinogens and cancer risks and for certain groups. But again, less risk is not no risk.
Well, thank you so much. We're at the top of the hour plus 5 minutes, so we should give our final comments unless there's some questions or comments from the chat. Does Nabor-Stevens say anything?
Comments. I didn't really see any questions. I may have missed one.
Okay. Dr. Lawson will give final comments first.
Dr.
Dr. Lawson.
Lawson is on mute.
Okay. Dr. Hines, you want to give your final comments?
So as usual, we have covered a wide breadth of topics here today, and one of the things that really kind of stands out to me is really on being, to your point, as diligent as you can and looking for alternatives. It's not a whole lot of, it can't just be no, 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 right? Okay, now that you know that there are risks in certain places, what are some of the ways that you can mitigate your risk for the things that you're not prepared to give up all the way?
Thank you very much. Is Dr. Lawson unmuted yet?
Not yet.
Not yet.
Dr. Walks?
Yeah, I'll go. Dr. Maxey, thank you very much for putting this together. I think what is for today's Black Health Trust, I think it was great that we had some content for all of us folks who are just trying to live our lives, and then we had some additional content for this is what the doctors ought to do. This is what the house staff should do this and do that. So I think it takes all of us to try to improve the health of the community. Those of us who are the quote unquote patients or consumers doing our part, and then the providers being willing to maybe push the envelope a little bit, maybe not just say, oh, your insurance company won't cover this, but as Dr. Gibson put in the chat, ask your provider if they'll complete a treatment authorization request or a TAR request, so that maybe the insurance company can make an exception because you're asking and your health is on the line. So we can't just accept the first no or accept, well, that's not how it's usually done. We deserve better than that.
Dr. Neighbor-Stevens?
Well, today's talk kind of brought me back to what I usually say, which is, we have a lot of information and there's a team. It's not a one person task to get all of this done, but don't forget your common sense. If they're advertising something heavily on TV, ask yourself why.
That's a really good point. Really good point.
Dr. Lawson's unmuted, Dr. Maxey.
Dr. Lawson?
Yeah, I just want to note another point. I mean, all of these involve individual decisions. Sometimes we have to get the community involved. When we talk, in many of our places are what we call food deserts. Even some of our wealthiest communities don't have grocery stores. Where do people get their food? From these fast food snack places where such issues as making sure that the food is changed regular, making sure we get some of these quality foods, making sure that we get the right foods. The option simply does not exist. And I've worked with community groups who literally had to fight to be able to see if they can get stores that can provide the kinds of foods that we need. And then just want to also mention the mental health issue. Much of what determines our eating is determined by emotional state and lead to what we call heedless eating. And that is that when folks are worried, stressed out, and so forth, they don't look on the package inside of how much sodium is in it and what's going to happen to them in the long term. They look at it in terms of now. And now again, I want to throw in a point with my colleague, Dr. Chapman. We now have medications that can effectively treat addictions. Yes, talk therapy, supportive therapy, community, all that's good. But even if the person doesn't want to participate in that, we have agents now that can reduce cravings from many addictive drugs, so that while they're getting the therapy and all that together, they can begin to live meaningful lives.
Thank you very much. As my final comment, I reviewed a lot of information to put these slides together. And one thing that I looked at, Dr. Walks, wanted to take away your pancakes, but also potato chips and Fritos. And I had to eliminate some of those slides. But the big takeaway is that most of these things that can harm your body and shorten your life have an increased and amplified effect to people of color in our neighborhoods and what we do. There's also been a push recently to have all these energy drinks, and I know I like to drink the Gatorade and all that kind of stuff. And turns out, unless you are a Class A athlete, Olympian, sweating for hours at a day, you don't need those energy drinks and those water drinks. Plain old water is still the best treatment. All the other things have stimulants in them. They make you urinate more. They have sodium in it and sugar in them. So just drink water and be hydrated. Thank you, everybody. Enjoy your Sunday afternoon. Happy Valentine's Day. Everybody on the line, have a great day. Thank you, Simon, very much.
Good day, everyone.